Well, thank you very much for allowing me the opportunity to speak today. Thank you, Teresa, and the rest of the Oncofertility Consortium, give me the chance to speak. The last talk was really interesting for me. I mean, just to think about the ways, so many complexities that face all of us when we're caring for these patients. This slide really is some of the things that originally motivated me to carry out this kind of work, is that there are a lot of children, a lot of men who are faced with cancer and the risk of sterility. In terms of their cancer treatment, many of these men and many of these boys survive, and so they are able to think about things after cancer care, and reproduction and other quality of life issues, but particularly reproduction and sexual function are often really important parts of this. So I decided to ground this particular talk in a series of case scenarios that I've seen. So this particular patient was a young man, 29-year-old patient who had testicular cancer, and he'd undergone a right orchiectomy a few years ago, opted not to bank sperm at that time, and because of the nature of his malignancy, he had a high risk for recurrence and received BEP chemotherapy, 3 cycles of this. His spouse was also young, had never been pregnant before, was healthy and fertile. So when he came in to see me, his laboratory evaluation showed that his testosterone was normal. His FSH, generally normal is less than about 8. His FSH was very high. His luteinizing hormone was also elevated. Typically less than about 10 or so is considered normal. And his semen analysis on a couple of occasions showed very low numbers of non-motile sperm. So this is a virtual azoospermia case. Sometimes these patients will have what we'd call cryptozoospermia, which would be sometimes they'd produce a semen sample with a couple of sperm, and other times they would be completely azospermic. So many of the questions that will come up for these couples will be questions like, when should we start, when could we start considering sex for pregnancy after chemotherapy? Generally, we'll advise birth control for at least a year after chemotherapy, just because of elevated risk of DNA damage from the chemotherapy. And sometimes questions will arise about how toxic the semen itself is. And generally, that appears to be a low to non-issue. So what are some of the ways that this particular patient could move forward? They could wait longer. Rather than progressing with some of the things we're going to talk about next, this couple could wait longer. And for patients who've been exposed to BEP, as we'll talk in a couple of slides from now, there is a chance that the sperm quality could improve. And what they're faced with right now is not necessarily what they're going to see in a few years. His partner is young, and that might be a reasonable option. We could do a microsurgical testicular sperm extraction, and any viable sperm that we see from testicular tissue, we could use that for in vitro fertilization in ICSI. They could opt not to go through this surgical approach, not to go through the expense of IVF and ICSI, instead could find a sperm donor and do intrauterine insemination, or they could choose adoption. In terms of the microtesty itself, this is a standard of care procedure. This is something that reproductive urologists do all the time. This can be done either under local, it can be done under general. Typically in my own practice, I'll do this with local and sedation. It usually takes around 2 hours or so, and then the lab time is usually extensive. Often it takes at least 2 or 3 hours of time. In complex cases, there can be 2 or 3 embryologists who are looking for sperm, and it can take many hours. The chance of success really depends a lot on the kind of chemotherapy or radiation that this person has received. If we were to know the histology and had that information, that can also help guide us in terms of our success. For this particular patient, just in terms of having a full discussion with them ahead of time, often the kinds of questions that will come up for us before patients are exposed to chemotherapy are, what can it do? And so essentially the range of potential problems are 0 sperm counts, severe oligospermia, or just oligospermia, or also poor quality sperm, or functional problems with sperm. And in the case of some pelvic or retroperitoneal malignancies, testicular cancer is one of them, you can have metastatic spread to the retroperitoneum, and then removal of those tumors can interrupt nerves that are important for ejaculation. Particularly for radiation, whether it's radiation for brain tumors to the brain or direct radiation exposure to the testis, hypogonadism is also possible. Some of the relatively lower risk chemotherapies are those that are on the list here. But I think one of the important things really is to emphasize that there's really no risk chemotherapy, is that it's important for patients to bank. An understudied area is many of the newer targeted cancer therapies, and whether these are mTOR inhibitors or tyrosine kinase inhibitors, there's reason to think that there could be fertility effects of these therapies. In the case of tyrosine kinase inhibitors, I've found them interesting, and that because of the mechanism by which they work, it's possible that they could not necessarily affect spermatogenesis like alkylating agent chemotherapies could, but they could affect functional properties of sperm. They could affect acrosome reaction, they could affect capacitation for sperm, and actually just affect, while the patients are taking them, they could affect functional properties of sperm. And during holiday periods off of TKIs, those patients might actually be fertile. It's just an area where we need to think about this more and do more research in the area. Higher risk therapies are like those in this particular patient. And so BEP, ABVD, these are therapies that have a higher risk of permanent sterility. But in the case of BEP, the majority of patients will actually recover given enough time. And then our highest risk chemotherapies are our alkylating agent therapies. And many of these, particularly the ones we use for bone marrow stem cell transplants, these are therapies that have an extremely high risk of impaired fertility or sterility. From a radiation standpoint, location and dose matter a lot. And so from a fertility standpoint, azoospermia is likely if the gonad receives more than about 3 gray, and lower doses can also significantly impair fertility. From a testosterone standpoint, the prepubertal testis, if it receives more than about 20 gray direct to the testis, it can have a permanent effect on testosterone function, and more than 30 gray for postpubertal testis. So today, if this patient decided that they wanted to have a treatment today, wanted to start conceiving right away, because the patient has all non-motile sperm, those sperm are generally going to be dead if I were to use those sperm that he had ejaculated. But on the other hand, the fact that he actually had sperm in his ejaculate was a terrific sign that I was going to be successful with the microtessy. So when I do the microtessy, what I'm doing is I'm essentially bivalving the testis, and I'm looking carefully throughout all of the seminiferous tubules that I see within the testicle for areas of bulging tubules. And it's those that I selectively pluck out and then give to the embryologist, who dissect the tissue out and then look for motile sperm or even just barely moving sperm. Even non-moving sperm from the testis often can successfully fertilize eggs. So this slide shows the overall probability of success. In terms of this particular patient, he would fall into the good category in terms of successfully being able to receive sperm, and I would say that the overall chance would be quite high in this patient. So today, basically our standard of care is to bank sperm ahead of time prior to receiving chemotherapy. And if a patient didn't have sperm, wasn't able to bank sperm prior to receiving chemotherapy, we could consider testicular biopsy and freezing this tissue. Both of these approaches essentially require, down the road, intrauterine insemination or in vitro fertilization. So the main point that I wanted to make about IUI and banking sperm comes from a counseling standpoint, is that one of the common questions that comes up is, how many samples should I bank? And so a patient comes in, and we often have this discussion about this distinction in terms of the number of sperm that you need between doing IUI or IVF and the quality of sperm that you're likely to get. Overall, we lose about half of the sperm that we bank. And so for a patient, if he comes in and he has 100 million sperm, at most I'm probably going to get 50 million after that. And so we try to bank that generally in aliquots of 10 million moving sperm, so that each of those vials could be used for an intrauterine insemination cycle down the road. But there's really not a good standardized protocol for how that's done. And to make this happen, I'm curious to hear how this is done in other institutions, because it often depends on the lab tech who's in there and who's freezing tissue. And I might get, out of that same 50 million sperm, I might get 2 vials, or maybe I get 5, or maybe I get 10. And it really requires focus on my part to reach out and talk to the embryologist or lab staff to say exactly how you're doing this. But it matters a lot ultimately for the patient. And so these are the discussions that I'll have, and we'll strategize, and we'll have communication about how many samples to freeze based on this. From an in vitro fertilization standpoint, we talk about really the fact that we really don't need very much sperm because you just need as much sperm as you have for eggs. So typically, I try to maximize this ahead of time to give couples as many chances at IUI and not necessarily have to do IVF, and we'll use those last couple of bank samples to use for in vitro fertilization cycles. So in general, we should be, cancer oncologists should be referring to reproductive urologists, REI, to discuss treatment. One of the things that's actually come up along these lines is really access to care, is access to being able to provide this kind of information right away. And something that's been growing more important in my own practice is using telemedicine. And this is another area where I'm curious about other practices around the country. And in California, recently, in the last couple of years, insurance companies now will treat a telemedicine visit just the same way from a reimbursement standpoint and billing standpoint as it would for a face-to-face visit. So it's been actually really helpful for me to be able to strategize in this way. This patient has produced a semen sample. We can manage that from afar, and then I can have a face-to-face Zoom visit and have this kind of strategy without making the patient come all the way up to UCSF, and it could be an hour, 2 hours, it could be a long trip for these patients. So why do patients tend not to bank? And we often don't know, but in this particular case, this patient was thinking, well, his risk was pretty low. He thought that BEP, he'd be fine. Other patients, though, will tell me there just wasn't enough time, particularly for leukemic patients, many of the young children, there really just isn't enough time. In other cases, banking is too expensive, and while there are philanthropic funds that can help some patients, often it really is just too much. Other times, it's just very difficult for the patient to get in, or the infrastructure in a particular institution isn't readily accessible. Other times, it's more of a knowledge gap from oncology docs or from surgeons not referring the patient. In the case of pediatrics, the knowing that this fertility preservation remains experimental. We found, at least in our tyrosine kinase patients, as we explore qualitative data out of these patients, we found that, as for other patients, there's often significant regret. And I think, as Emily and Courtney were talking about, just being able to explore these issues, giving patients the opportunity and the time and the space to process how they feel about this is really important. And whether they bank or not, just being able to talk to patients about it and work through these issues is really important. So in terms of counseling patients about the probability of normality afterward, for patients exposed to BEP, prior to receiving BEP, this was an interesting study that showed that only about 53% of those patients were normal, and 33% had oligospermia, 14% azoospermia. So at our institution, and as is for many others, referring early is really important, and knowing also that cancer patients' semen often thaws more poorly than that 50%. And for us, we've had many discussions about whether or not we can actually even bank samples that have been exposed to chemotherapy. They've thawed so poorly that for patients who've been exposed to chemotherapy in the last 6 months, unless they're enrolled in a research protocol, we just won't bank it. And there have been one lawsuit against UCSF in this case, even though the patient had been extensively counseled. The semen sample thawed, and there was no motile sperm. So moving along to a pediatric scenario, this has been another situation where telemedicine is actually growing to be very helpful for us in terms of providing fertility preservation care. This young boy was diagnosed with a brain tumor and was going to had the tumor removed and was going to be undergoing high doses of pretty toxic chemotherapy. Plan was for chemotherapy next week. He's going to be getting a lumbar puncture and a central line. His parents were really plugged into the system, and they asked us about measures to preserve his fertility and how can we discuss these options with them. Overall, the risk of sterility for boys are significantly elevated. The particular radiation alkylating agents are the biggest risk is for older patients. Being younger doesn't protect these boys. Using the CED is a way of estimating azoospermia, oligospermia, and normospermia is not a perfect measurement, but it can be helpful. And there really isn't a threshold dose, though, that can exclude the risk of oligospermia. There's significant overlap between all levels at the CED. And these estimates really were based on a cohort of 214 adult survivors exposed to chemotherapy and radiation therapy. So when I discuss these issues with families as they come in, and more, this has become a telemedicine consultation for me. In my own practice, I'm in an adult area of the urology practice at UCSF, and we split by location. Pediatric urology is in our children's hospital, and our adult urology is in the adult region of the hospital. And our particular clinic is not certified. Our nurses are not PALS certified. So because of that, I've been unable to actually bring parents with their child just sitting on their lap even, when I just need to have a consultation with them about this. But because this is, in some cases, a perfectly well kid who comes into clinic, and I can't talk to the parents about them because the nurses aren't PALS certified. I'd have to go down to the children's hospital to do this, which has been ridiculous, but this is what we faced. So instead, how have I handled this? And so we tried it on the phone for a while, but it became unsustainable to do that. But being able to do telemedicine was a way that we could actually bill for these visits and get some credit, while also providing access to these families. And it's been great. One of the recent ones, a patient who was about an hour and a half away, and this mom who I talked to, I can see her. She has her 3-year-old who's kind of bouncing around the house, and I can see this 3-year-old bouncing around in the background. I have the baby who had Wiskott-Aldrich syndrome, benign condition, who's in her arms, but she's able to just manage both of these kids while still talking to me through the computer. But imagining having to bundle the kids up and then to bring them a couple of hours into UCSF and to sit them in, besides I couldn't do that anyway, has been pretty fantastic. And it's allowed me to do this. And so I can now just ad hoc, just add patients in quite quickly at the end of the day or the beginning of the day, in between cases, whatever it may be. And I think families have been very happy with this. So what I discussed with them is the possibility that at the time these children are getting a central line, some other procedure, that I could do a testicular biopsy, and there's a possibility that tissue could be used down the road. We could either grow sperm from them in vitro, or we could potentially transplant this tissue back to these children. This pediatric biopsy is pretty simple. It takes less than 30 minutes to do. Take this tissue out, and in the case of these prepubertal boys, there's no sperm, there's stem cells. There are many ethical considerations that I just wanted to go through, and I found these quite interesting. One of the reasons why I first started exploring this particular area was that I found that one of the areas of pushback in building a pediatric fertility preservation program was from one of the oncologists who was a really devout Roman Catholic. And he expressed a lot of concern to me about doing in vitro fertilization with this tissue. And it made me just really wonder about many of the issues that we often don't have time or space to explore with our patients. And so the questions that have come up are these ideas of patient autonomy and giving patients an opportunity to do what's best for them, doing good for patients, not doing harm for patients, and also what do we do about tissue ownership and consenting for these patients. So from a patient autonomy standpoint, we want to respect individual preferences, but many of these children are really young. In the case of this 8-month-old child or this 3-year-old child, they really can't make these kind of decisions. So what about parents, and what about their rights? And this idea of having the children having a right to an open future, that we're trying to preserve the options that they have down the road and not putting barricades up for their future options, became a really important and influential for us in our decision making. Well, we want to do good for these patients and by offering testicular biopsy, but we have to be realistic about the chances that the work that Dr. Orwig and others are doing, how likely is it going to be for these children? And so for us, being really upfront with these families about where the state of the art of the research is really important. And so for now, continuing to state that these sort of prepubertal testicular biopsies should be done in the context of an IRB-approved research program. So what about doing harm? So a number of these patients who are exposed to toxic therapies will still have fertility. What is the risk that's actually acceptable to put these patients through? found that the risks of the biopsies themselves are really low. If in the short term, very mild bruising, swelling, discomfort, infection. I actually have in about 30 of these biopsies that I've done now, I haven't seen a skin infection, and most of these children are receiving bone marrow transplant or getting the chemotherapy within days of the biopsy. Are there long-term risks? Additive diminished fertility or hypogonadism risk? I doubt it, based on the size of the biopsy that I take, but that's something that we really don't know. From a cosmetic standpoint, often fathers will ask me whether or not the testicles are going to be abnormally shaped, but I generally reassure them that's probably going to be just fine. So from a consenting standpoint, our standard consent forms when we consent adults have 3 options, and adult patients have to choose if you were to die and if we had stored this semen or other tissue, what would you want us to do with that tissue in the event of your death? Well, you could discard it, do research on it, and then discard it, or typically for adults, you would allow your spouse to decide what to do with the sample. And that's what our original, in our IRB, we'd written a pediatric protocol that had those 3 options, but the third option was allowing the next of kin, or allowing the mother or father to decide. So we had a child with a benign condition and ended up passing away from the complication of the bone marrow transplant. And the mother came back to me and called and said, "Dr. Smith, well, I'd like to do something with this tissue. What can we do with this tissue?" And you imagine the kind of complexities of what would that child have wanted? Even if we could grow sperm, where do you get an egg? Who's going to carry that child? We quickly realized in consultations with our ethics group, our legal group, that it didn't make any sense to do that. So that's not an option that should be offered. Really only for these pediatric prepubertal patients, the option to discard or do research with sample and then discard are really the only 2 realistic options. So is it the right thing to do? Are we doing more good than harm? Child's really too young to make a decision, but having the parents decide what's right and allowing children to have the right to an open future. And so does this testicular, do benefits really outweigh the risks? And I think that's an important discussion to have and to go through these issues with every patient. So for this particular child, decided to perform a testicular biopsy at the same time. They had questions about cost and insurance coverage, and they also asked about future uses for the tissue. So fertility preservation, as Joyce and others in the field can attest, many in this community working very hard to make fertility preservation standard, but it really isn't. The cost of tissue cryopreservation, though, for boys is a lot less. It is a lot less involved process. Most of the time, for most of these patients in my practice, the cost of the testicular biopsy, if anything, they pay the professional fee of the testicular biopsy. Even that is often, we can bundle into the rest of their clinical care. And so in most of the cases, insurance authorization happens, but patients will have to pay for the long-term cryo of this tissue. Some of the practical issues that I think affect whether or not urologists are open to doing this is that the procedures themselves has very low reimbursement. There are low RVUs, which increasingly is a way that physicians are measured. And so if this isn't an area of their interest and expertise, some of those practical considerations could be important in terms of whether or not a doctor is willing to do all the extra work and coordination and time that it takes to do these procedures. In this particular case, this 3-year-old, the insurance denied the approval, but the family opted to go forward anyway. So how is this similar for transgender children? So more and more over the last couple of years, we've been asked to consider doing biopsies or sperm banking for transgender women or girls. And so these patients, they're facing sterilizing treatment in the case of bottom surgery or orchiectomy sometimes, or medications or hormonal therapies that patients are on. But for the prepubertal children, is there a rush to do a biopsy? Is there a rush to an orchiectomy? Many prepubertal trans girls are suppressed with leuprolide, and so the gonads are suppressed for extended periods of time. So I'll see a patient who's 9, 10, or 11 years old, and should I be doing a testicular biopsy right then, or should we wait so we can think about it for a longer period of time? One does need to make a decision if they are proceeding with bottom surgery and going to do an orchiectomy. And postpartum patients offer using spironolactone and estrogen rather than leuprolide. So this particular mother called me, and since age 9, this now 13, so for 4 years, the patient had been suppressed with Lupron. She was planning to have bottom surgery and have bilateral orchiectomy at that time. Her Tanner stage was 2. She had 4 milliliter volume testicles bilaterally. And so some of the questions that often come up are, how do these medications that are used suppress testosterone, given to suppress testosterone affect spermatogenesis, and what fertility preservation options are available for these children? So for this child, I received both of the testicles, dissected through the tissue, and I was very interested to see, even though the child had been on Lupron for a number of years, was still able to see what looked like secondary spermatocytes in this tissue. And so we ended up preserving this testicular tissue. The pathology report was reported as Sertoli cell only, but at least from a clinical standpoint in our embryology lab, we were able to see cells that looked like they might be haploid and possibly could be injected for ICSI, and there would be spermatogonia in this tissue as well. So this particular child we opted to enroll in our research protocol and save this tissue. So from a male reproductive endocrinology standpoint, hypothalamus is releasing GnRH in a pulsatile fashion, and this in turn leads to FSH production, which is important for spermatogenesis. Luteinizing hormone is also released, and that's important to stimulate Leydig cells to release testosterone. And both of those together, both testosterone and FSH, are important for spermatogenesis. So Lupron is suppressing both FSH and LH and leading to very low levels of testosterone and zero sperm count in all the patients who I've seen so far. Spironolactone, on the other hand, is decreasing testosterone production and has a variable effect on sperm production. In a small study that we did, we looked at 14 transgender postpubertal patients, collected 43 semen specimens, and we found that semen volume was lower for patients on spiro and estradiol. Concentration of sperm was lower, motility was lower, and the total motile count was also lower. The number of vials was lower. But really the important part for us is that before we wrote this paper and before we looked into our patients, we just didn't know at all. We didn't know whether or not it was even possible. And there was the common belief was that for trans patients, you'd have to come off of medications for 3 months or longer. And that was something that made patients really uncomfortable. The thought that the kind of gender dysphoria that they were going to have to come off for an extended period of time when they've been on these medications for a while was really a very unpleasant idea. So it was very encouraging for us to see that you could successfully bank sperm even while on therapy. So this slide basically is from one of Kyle's recent reviews, and I just wanted to discuss from a broad standpoint a number of the options that are possible. So for postpubertal patients, banking sperm is the standard of care. Banked sperm can be used for intrauterine insemination, can be used for IVF and ICSI. For prepubertal patients, or for patients who weren't able to produce a semen sample, testicular biopsy can be performed. You could break this tissue down into individual cells. And in terms of how you could use that down the road, one way, once you had this cell suspension, is you could culture this. You could figure out all the right culture conditions, culture those cells, and once you'd had enough spermatogonial stem cells, you could inject those cells back into the testis and potentially see enough sperm production to allow natural fertility. You could also try to induce the production of organoids that could produce sperm, recover the sperm from that culture system, and do in vitro fertilization in ICSI. Could also, alternatively, another option would be to take a testis biopsy, keep the actual testis biopsy intact, take the testis biopsy, place it perhaps back under the tunica albuginea, and see sperm production from that sample, pluck those cells out and do ICSI. And other potential options could be organ culture with that intact tissue or potentially xenografting. And both of those techniques also would entail identifying sperm and then doing ICSI. And a third big picture option would be to do something like take skin cells and use induced pluripotent stem cells and be able to take those particular stem cells, turn them into sperm stem cells, and either inject those sperm stem cells back into the testis or induce those sperm stem cells to grow into sperm and use them for ICSI. So these options, in terms of the autologous testicular cell transplantation, this is a technique that's been successful for 25 years. And it does offer the potential for success with IVF or ICSI or in vitro maturation of spermatogonia, where you're going to be starting with a small amount of source material and would need to move on to IVF and ICSI after that. From Kyle's lab, it's been really exciting these last several years to know that it is possible for both prepubertal and postpubertal patients, monkeys, that undergo a bone marrow transplant to take a testicle, process the tissue, inject it into the remaining testicle after a bone marrow transplant, and see the recovery of spermatogenesis. And from a clinical standpoint, I think where we need to be moving toward is to start trying this for people, to take a testicular biopsy and to process this tissue, and for patients to be able to inject these cells back into the testis. And the technique itself, particularly for a urologist who's comfortable working with the testis, comfortable with ultrasounds, the technique of actually injecting a slurry of cells into the ready testis is very straightforward. Or the idea of taking chunks of tissue and placing it under the tunica albuginea, that's even more simple. So I think these are things that, from a practical standpoint, from an IRB standpoint, these are techniques that we should work toward developing. For questions about what exactly do we inject, this makes me uncomfortable if the patient had leukemia and I were to take a testicular biopsy, processing this tissue and injecting it back in, because even really small numbers of cellular contamination increases your risk of future malignancy. Other problems are you need to amplify the number of stem cells that you get. From a pediatric patient or from this 13-year-old who had stem cells there, there are going to be very, very low numbers of sperm stem cells. So developing techniques to be able to amplify the number of sperm stem cells is really important. From a transplanting standpoint, one of the things that is interesting to me is the potential this might be a lower cost technique, and it may allow techniques like IUI or natural fertility rather than doing in vitro fertilization. And I think that it's possible that if these techniques were to progress further, it'd be possible to offer not only semen banking but also tissue banking for adult postpubertal patients. And so I could imagine a situation where adult patients were banking semen just in case, banking tissue just in case, but then trying to transplant this tissue back for adult patients and seeing whether or not you see resumption of spermatogenesis for them. Access to all of these services is difficult in many places, and insurance coverage is difficult, but perhaps for a transplant it might be less expensive than for IVF. I showed this slide, really was interested. When we wrote this paper, we were looking at distribution of male factor infertility, but it really showed a nice map of access to care. And the white spots on the map, really areas where there are no IVF centers, and even in places like the central part of California, there are very few IVF centers, and families are traveling many hours to come to places in Los Angeles, or San Francisco. The costs of fertility care are quite high, and when we're talking about banking sperm and then using this down the road, families need to know that it can cost thousands of dollars for IUI, for in vitro fertilization. The out-of-pocket cost for couples doing IVF was around $20,000, and these were couples who were followed for about a year and a half. Well, what about in vitro maturation of sperm? So, a number of years ago now, it's been shown that you can take newborn mouse tissue and grow this newborn mouse testicular tissue in a three-dimensional gel and pluck out sperm and do in vitro fertilization and have multiple generations of healthy mouse pups. So it's exciting to know that this kind of thing is really possible, and it motivates us to continue to have these kinds of programs. But we still need to continue to work more about understanding spermatogenesis and understanding all the factors that go into the growth of sperm stem cells. And identifying the markers that are important for selectively finding spermatogonial stem cells, Sertoli precursor cells as well. So some of the challenges that remain are logistical challenges. I think telemedicine has been helpful for us in terms of expanding access. Continuing to measure fertility outcomes. I think this is an area of needed research. How big of a biopsy should we take? Should I be taking a whole testis as opposed to a 5%, 25% of the testis? How do we differentiate SSC to sperm? How important is the niche, and how can we maximize these protocols? Is it better for us to take this tissue and place it under the tunic as a way of recovering sperm? Doing actual individual cells and transplanting SSC, or is the induced pluripotent stem cells a better model for us? So in terms of our take-home points, it's really important to have open dialogues and collaboration between all specialties, and having social workers, oncologists, nursing, lab, urologists, REIs, having everyone in the same loop is really helpful, and referring as early as possible. Sperm or tissue banking prior is the best way to go. That testicular biopsy remains experimental, and we need to continue to form individualized plans for each patient, and the sort of research collaborations that we can develop as part of Oncofertility Consortium are really critical to moving this field forward. So thank you very much.